My mom was a teacher and she always wanted me to be a writer. And my aunt was an oncology nurse. And she always told me she died of brain tumor. And she told me before she died that if I ever spoke to patients like a doctor instead of like a human, that she would make sure that she came down and whacked me on the back of the head. So I have been trying to do as good a job as I can possibly do, Aunt Diane, of trying to sort of translate the story of science into the story of cancer. And the really exciting part, and I think the challenge for where you all now are, is that we're on the cusp of some really cool and exciting things happening in lung cancer. I was reading today that in the 1993 budget, for the first time, they actually decided to study and force clinical trials to include women. And it was also the first time that advocates ever directed Congress on what they wanted to spend money on. And that was part of the breast cancer advocacy movement. And they were all very excited because at that point they had gotten about $300 million from Congress. But if you look farther down into the federal budget, it was also at the same time that the federal government was spending about $100 million a year subsidizing the tobacco industry. And that was just in 1993. So if you think about how short of a time frame that is and how far we have come, I think we spent a lot of our time, especially in a disease like small cell lung cancer, we spent a lot of the 90s and 2000s looking at different ways to poison cancer cells. So the majority of clinical trials in every type of solid tumor were sort of based on this amazing cure rate they found in the 70s and early 80s for liquid tumors like leukemia and lymphoma. For the first time ever, they could cure childhood leukemia and they could cure young people of Hodgkin's disease. And they started on those two diseases because honestly, in the 70s, those were the youngest people and they were the only people that could survive that chemotherapy. But because of that, because they had these tremendous responses, the sort of Nixon's war on cancer that started in 1971 really directed a lot of funds towards finding chemotherapy agents for cancer. And if you think about what it takes to become a cancer cell, especially as Pam mentioned with the prophylactic cranial irradiation or the PCI, you guys are part of the only group that will ever hear those words. There's another rare cancer in kids called Ewing sarcoma where we do prophylactic radiation to the lung. But when you talk about this, people are going to think it's like totally a bizarre thing. And that's because, from what we can tell, small cell lung cancer cells are some of the most aggressive cells. They're like the Army Rangers or the like Marines of cancer cells. They have already developed the ability to get out of the lung into a blood vessel, across the blood-brain barrier, and hang out in the brain. And so to think that we're going to take these like highly evolved, very aggressive, and they can like set up shop, as someone was sharing, in the liver. The liver is not a hospitable place for lung cells. Like if we drop some regular lung cells in the liver or the brain, they would die because that's not what they're supposed to be. And the liver's like, hey man, what are you doing here? We can't, this isn't a lung. But because cells like small cell have developed these different mutations, they are able to live in very inhospitable places. And because of that, there wasn't, I mean, just the last 20 years of research of trying to find more toxic therapy to throw at cancers just was never going to work because the organs, the natural organs that they were in, were going to cry uncle way before those extremely developed and aggressive cancer cells were. So I think what's been really exciting, and I sent this to Dusty and Lynn, I was at a multidisciplinary lung cancer meeting in New Orleans a couple months ago, and it was the first lung cancer meeting that I had ever been at where there were multiple presentations on immunotherapy and on other targeted therapies that were not just how do we balance like not killing the cancer without killing the patient and sort of, hey, we can kind of do this. actually looking at and coming up with a different word than small cell lung cancer. Like that's like basic microscopes. Like we need to know what these cells are actually doing. And so there were several investigators. And to me, I've been in oncology for about 20 years now. It's really exciting when I see young people going into small cell, because I saw this about 10 years ago when young investigators started to look at brain tumors. And whenever you see a young person say, hey, I think there's exciting science there, then that to me triggers that there's something cool going on. And I think what's going to be hard, and what's always hard when you're in the midst of this, is things are going to be changing, I think. And I think that's why Dusty and Lynn doing this group and Montessa being a part of it, is that I think you guys are going to be inundated with more probably questions than answers, and a lot more trials than you're going to just be like, what? And I thought this, and I thought that, and someone else. And so staying up to date on small cell lung cancer is going to be not more difficult, but a lot more challenging. And so I think connecting people to groups like this that are bringing in these doctors that are thinking about this is going to help you become better advocates for yourselves and also better advocates for this community. And I'm just really excited about that, because instead of just looking at cells under a microscope and saying if they're small cell or non-small cell, now we're actually looking at like, what is the mutation? Like, what makes this cell so crazy? And then how can we start targeting that? And that's the really exciting part. And I think that's where we're going to start actually pushing back and seeing some different changes in small cell lung cancer. And unfortunately, radiation will, I think, hopefully the medical oncologists are going to be putting us out of business. And I would love in 10 years for none of you to ever have ever talked to a radiation oncologist, because we have targeted therapies. So as radiation oncologists, radiation is not very specific. It's a little bit like surgery. Surgery is, a scalpel, radiation's just x-rays and photons. But I can talk a little bit about it, because I do think that there are some strange things about small cell that are just different. And when you talk about it, especially this whole PCI thing, and Pamela did a great job of talking about radiosurgery and these other different terms that you might hear. And especially when you're in a mixed group, when you talk to other non-small cell lung cancer patients, they might say, oh, well, I got that, or, oh, well, I got that. And I think sometimes it can be like, well, why didn't I get that? Or why didn't my doctor talk about that? And so to be able to at least have a conversation with your doctor, or to have a conversation with yourself, is like, okay, this is why they didn't, and this is the approach. There's been such dramatic responses in immunotherapy that actually radiation oncology is doing a trial on different ways to do PCI as well, because patients are living longer. So I'm just going to, if you guys can just put in the chat for Lynn any specific questions that you have, because I want to make sure that I get to those. I know radiation can get very technical very quickly. So definitely put those in the chat, and I will be sure that I answer those. And I'm just going to go over, I have like maybe 10 slides, just so that we can get on the same page as far as terminology goes. So when you're talking to your doctor, or you're talking to somebody else, whenever you talk about cancer, whenever you talk about survivor, if you don't like get everybody on the same page, then I feel like people aren't thinking the same way. This is this is part of a presentation put on by my professional organization. So most of you are probably familiar with sort of the surgical options. And for those of you that have very limited stage small cell lung cancer, or have had a stage 1 or an early diagnosis, you may have gotten surgery plus or minus chemotherapy. In chemotherapy, and I'm only sort of an amateur medical oncologist, so chemotherapy is what we think about when you think about chemotherapy, people losing their hair, throwing up, that sort of thing. And that is sort of the typical way that we have approached small cell lung cancer. Immunotherapy and targeted therapy are used interchangeably. And I want to just sort of put in your brain, targeted therapy is something you guys maybe have talked about, ALK receptors or EGFR receptors. Targeted therapy is when we find a mutation on a cancer cell that is only on a cancer cell, or is it a super high percentage at a cancer cell? And then we can sort of, it's like a key in a lock. And we found a key that can go into the lock of that cancer cell, and that is targeted therapy. Immunotherapy is where we can somehow turn on the body to look for that lock. We can sort of train the body or use the body's own immune system or its own mechanisms to go forward and fight the cancer itself. So those things, I think, are going to be the best ways to treat cancer, because we're using our own body. Our bodies fight cancer all the time. And to use targeted therapy, because that no longer is like, let me just see if I can kill, somebody was talking about blood counts. Let me see if I can just get the blood counts low enough that I can kill like 50% of the cancer, but not 100% of the blood counts. And that's not really targeted. Then we're just like, mixing poisons and seeing how far we can go. Targeted therapy and immunotherapy, I think, is going to be a game changer for small cell lung cancer. And I'll talk a little bit then about radiation. For those of you who have had radiation and chemotherapy together, that's what we call conventional radiation. And we use two words. One is 3D and one is IMRT. Most of you have probably had, if you've had radiation in the past like 5 years, you've probably mostly had IMRT. They're essentially the same thing. And what it is radiation coming from the outside of the body going to the inside of the body. And that radiation is not targeted. It is damaging normal tissues in addition to cancer tissue. And it's creating basically damage in the DNA of cancer cells that those cancer cells can't repair. Typically, the sort of conventional radiation or daily radiation is given at about 1.8 or 2 gray. That's the measurement we use, which is just like inches or pounds or cups or quarts. We use gray as our measurement, and it's usually given in 30 to 35 fractions or daily treatments. And that is usually to a total dose of somewhere between 60 and 70 gray. So usually, again, 30 to 35 treatments. And in some, there's a whole big controversy in radiation on whether we should be giving small cell treatments twice a day or once a day. It doesn't really matter. Small cell you can give twice a day. It's from the 70s. I'm not going to get into it. But you can have radiation for small cell either for 30 days, 30 to 35 days, or twice a day for 15 days, and both of those are fine. And that's called conventional radiation, daily radiation, and that a lot of you may have had at the beginning. This is where things get sort of complicated, and that is something that's called SBRT. Some people call it SABR. Some people call it SRS. All of this starts with an S because it's called stereotactic radiation. Another thing you might have heard is gamma knife or cyber knife. And this is usually or typically used when there is a very small lesion in a patient who can't have an operation. And that is usually given in about 3 to 5 treatments. And it's a very high dose of radiation given to a very small area. So if you can see down here on the right, this is external radiation. So it's just like the previous radiation, just like IMRT or 3D radiation. It's coming from the outside of the body in, but it's in a very small localized area. So we're basically condensing 6 or 7 weeks of radiation into about 3 or 5 days of radiation. And so you want to be very sure you know where that radiation is going, and it also can't be any close to any critical structures. So you can see here this lesion or this tumor is in the middle of the lung here. It's not close to the esophagus. It's not close to the heart. That amount of radiation given in that short period of time can be very dangerous if given to critical structures. So really, this is a very narrow use of radiation that you might, typically it's used in non-small cell lung cancer patients. I'll just talk briefly about radiation toxicity. I just did the chest here, and we'll talk a little bit about brain toxicity. A lot of radiation toxicity or side effects is determined by the tumor site. So especially in this image on the left, if the tumor is right up against the chest wall, we may fracture a rib due to radiation. It's just where the tumor chose to grow. If the tumor grows, it's going to fracture the rib, and the radiation can long-term cause some chest wall pain or rib fracture. There is 100% chest wall pain if you have surgery. So that is something that can happen. And we usually say in about one in 5 patients can expect to have a rib fracture. On the right side, you can see a little bit bigger tumor. This might be a 3D or an IMRT plan. You can have some, obviously, fatigue when you're getting chemotherapy and radiation together. Sometimes there can be some inflammation of the lung. Especially, you can see here this little V structure here. This is the left mainstem bronchus, or the left mainstem part of the breathing apparatus that's coming and dead ending right into this tumor. So when this tumor dies and turns into scar tissue, it can be that scars off that lung, and that no air is able to get into that lung. It's due to scar tissue, so it's a good thing because it's not tumor. But that can lead to the lung collapse, or even can sometimes cause some hemoptysis. Sometimes coughing up blood. Sometimes patients are already having that because the tumor has abnormal blood vessels, and that's draining into this bronchus already. So for some patients, that's something that brings them to the doctor anyway. This is sort of a rubric that I put together of how we think about treating small cell lung cancer. So when you walk into small cell lung cancer, we are now becoming more cognizant of staging small cell lung cancer, just like we do for non-small cell lung cancer. So typically, if you have a node-negative, small, tiny tumor that is a small cell, you would get surgery. They would remove your lymph nodes, and oftentimes you would get some chemotherapy. It's extremely, extremely rare to do SBRT for small cell. I've done it maybe twice in my career. That's that very focused radiation when patients are not a surgical candidate. The majority of patients are going to get chemotherapy, and this is right now, February 26, 2024. ASCO is every June, so this can change. I mean, I feel very optimistic about small cell lung cancer over the next couple of years. So right now, in February 2024, our standard approach to small cell lung cancer is the same as it was 10 to 15 years ago, and that's chemotherapy and radiation together. Again, I'm not going to get into the nerd fights that we have at meetings on whether we should start with the first round of chemotherapy or the second round of chemotherapy. It's really not important. But we need to start chemotherapy and radiation together. Sometimes it takes us radiation oncologists a little bit longer to get our plans together. More often, it's longer to get insurance coverage now for radiation. So it can be that sometimes patients will start off with one round of chemotherapy, and then we'll pick up radiation on the second round of chemotherapy. And then typically what we would recommend if patients have a great response to treatment is we would talk to patients about doing, or we would talk to you all about doing brain radiation. And when I finished my training 20 years ago, the studies were just coming out that patients lived longer and they lived better if we did brain radiation. So it was like everybody needs PCI or needs brain radiation for a couple of weeks after treatment. No ifs, ands, or buts. You've got to do it. Now, and I'll sort of, one of my, actually a good friend, Chad Rustovan, has been talking about brain radiation, which I think is something that is going to be an area of controversy and an area of less therapy probably and less whole brain radiation. We also use radiation in small cell to symptomatic sites. So sometimes patients will come in and they'll have back pain, or they'll have leg pain or arm pain, or they'll be coughing, having some bleeding when they cough. And so oftentimes we could start with radiation, and radiation sometimes will make those symptoms better faster than chemotherapy will. Sometimes when patients have a larger bulk of disease, and I think I've had more and more medical oncologists coming to me, and patients have just had a tremendous response to chemotherapy plus immunotherapy. And they will say, now we want you to do radiation. We've got the cancer on the run. Cancer always works best when it's smaller. And they will be asking us to do radiation to the chest after a really dramatic response to some of these newer agents. So we're having more conversations about that. These are a couple of the trials, and there's another one that I've added on as well. And that, again, is adding on immunotherapy. Every trial you're going to see so far, there's a couple in small cell where they're trying to do immunotherapy up front, or in non-small cell where they're trying to do immunotherapy up front. But a lot of this is going to be in addition to. And so that's the way these clinical trials are usually going to run, is that they'll try it in patients that have had a couple rounds of chemotherapy and have their disease is coming back, or they're not responding anymore. That's when they'll do the first round of trials. Then they'll do it in patients that are new diagnosed and have stage 4 disease. And then it will come into the adjuvant setting or into standard of care plus immunotherapy. So for those of you that are newly diagnosed or are coming into this with a stage 3, stage 2, or stage 3 small cell, you can sort of be listening to the conversation that's happening in patients that have stage 4 disease, because the drugs that make it out of that, and drugs, immunotherapy or targeted therapies that make it out of those metastatic trials, are the ones that are really going to apply to you. The other part, or the cool thing that we're doing with radiation, so there's no new radiation since the sun was invented, Einstein discovered photons. So we can't do any new cool targeted therapy or any new radiation. People talk about protons, but that's just a marketing thing. It's nothing, not that big a deal. But what we can do is, and this is why we're physicist minded rather than the medical oncologist who are kind of biology minded, is we can manipulate our radiation. The same way that we were able to take the 6 weeks of radiation and condense it down to smaller treatments, into 3 to 5 treatments, we can also start to use our fancy radiation techniques to avoid areas in the brain that cause side effects. So the great debate in using PCI or in giving radiation without any evidence of brain tumors is whether the radiation makes patients worse than the cancer would. Obviously, this is a different conversation than patients that already have cancer in the brain. The brain is the only organ in the body that's completely encased in bone. There is no place, it's not like the lung, it's not like your leg, it's not even like a breast or a colon, where there's plenty of space for a tumor to grow. If a tumor starts growing in the brain, it can only get to a certain size before it starts causing a lot of problems. So we know that eventually a tumor is going to cause problems in the brain. Because of prior studies that showed that a lot of small cell lung cancers go to the brain and stay in the brain, there were trials done in the 80s and early 90s that showed that it was a good idea to give everybody, just to assume that patients had or were going to develop cancer cells, and those cancer cells were going to set up shop in the brain itself. So that's when we started doing PCI. What we found, though, and what some of these studies were showing, is that in patients that did really well with PCI, is that they had problems with short-term memory. And I'm sure many of you can attest to that. That seemed to be more of a problem in patients that were older. There's still a lot of plasticity in younger brains. So the conversation that I usually have with my patients now is in younger patients. This was also, unbelievably, this was also in the pre-MRI days, is when a lot of these PCI trials were done. So we were following people with CT scans, not MRIs. So the conversation I usually have is with young people. We can either do PCI, so we can do radiation for about, a couple weeks. And that is the safest and best way that we know of to prevent cancer from setting up in the brain. Or we can monitor your brain with MRIs every 3 months and hope that we find small, tiny little cancers before they turn into something that's a problem. And that is an option that I talk to patients about. In my older patients now, and as I approach 50, older is becoming. Oh, yeah.
Can you clarify older and younger? Somebody is asking.
Yeah, exactly. Yeah, it's becoming, yeah. So for anybody usually under 50, I am still recommending PCI. For anybody sort of 50 to 70, what we know now is that old brains do not do well with PCI. There's already sort of age-related cognitive decline caused by normal aging and atherosclerosis that can really be accelerated with whole brain radiation. And so in my older patients, now what would I do with a 51-year-old? We have a conversation. But in older patients, definitely 70, 80, 90, I'm not talking about PCI anymore, and we're just going to see how it goes. For younger patients, I'm still recommending PCI. NRG is just a group of all of the cooperative groups in the whole country that have come together to do clinical trials because, as you know, small cell is relatively rare and it's almost impossible for one organization to do a small cell trial. There's just not enough patients. So they have formed these consortiums where they do these trials all over the country. This one is saying, hey, we'd love to do PCI on everyone, but maybe we can make the younger people's brain think better. And maybe we could give it to older people if we could avoid some of the things that cause them thinking problems. The hippocampus is a very sensitive organ that is responsible for laying down new memories. It is not responsible for old memories. So this isn't like Alzheimer's or anything like that. But part of the reason that chemotherapy and radiation cause thinking problems, especially in new memories, again, it's not like Alzheimer's where you forget, who your parents were, but that where are my keys? Oh my gosh, I forgot my doctor's appointment, or just that recall that seems like it takes a while for things to sort of move to the front of your brain. A lot of that is because the hippocampus is very sensitive to chemotherapy and radiation. So one of these trials is looking at what if we can carve out little circles around the hippocampus and make sure that very low doses of radiation get to the hippocampus? Can we then make people's thinking better? Can we make patients thinking better with avoidance of that? And that's just a fancy way of determining whether we can use radiation. So this is that trial. And what it's actually doing is it's looking at patients who would just get normal these are all non-metastatic. So these are patients that don't have any brain mets, do not have any cancer that's spread to their brain yet. And we're looking and they've had great response to chemotherapy and radiation in their chest. And they've been referred and we're saying, okay, we would recommend, you're 40 years old, we would recommend PCI for you. Now, what we'd like to test is whether this new fancy radiation where we avoid the hippocampus, if that's as good or if there's any danger. Maybe if we avoid the hippocampus, there's cancer cells in the hippocampus. And so it's a bad idea to avoid that. So that's why we're doing this clinical trial to see if this helps. It may be that the hippocampus is so sensitive, it's sensitive to just one unit of radiation, so we can't do it. But if we could maybe make that memory better, using our technology, that would be beneficial to patients. So this is for PCI, and this is a trial, and it's actually accruing really well. So there's patients signing up for that, which is really great. The good thing about this trial is you get whole brain radiation regardless. It's just this avoidance of hippocampus that is the new, or that's the question here. And we've done this in other diseases, and it does not seem like the hippocampus is a place where cancer cells like to hide. So there's not a thought that this is going to be dangerous for people. What we don't know is if it's going to be beneficial. So I think this is a relatively easy trial to accrue patients to because both sets of patients get PCI. So what about what about patients who already have cancer in their brain? So right now, whole brain radiation is the standard of care for small cell lung cancer. So you might hear in other areas that people with non-small cell lung cancer get things like Gamma knife. Pam mentioned getting that after her cancer came back in her brain after having PCI. The reason for that is that non-small cell lung cancer, in addition to just being a different shape, which is why we call it non-small cell, again, completely ridiculous. We should be calling these things based on their genetic mutations, not just based on what they look like under a microscope. It just embarrasses me that in 2024, that's what we're still doing. Previous trials looked at, can we do whole brain radiation, or is it safe to just do gamma knife or just target the little areas that are of cancer in the brain? Those did not include small cell. So the reason for that is that doctors think that small cell is present in different areas of the brain that we can't see. Now, unfortunately, no patient will allow us to take out their brain, look at it, see if that's true, and then put it back in their bodies. We've had a hard time recruiting patients to that trial, so we don't know if that's true. And even in trials where we take out a little bit of the liquid that's around the brain called the CSF or the cerebral spinal fluid, sometimes that's negative and doesn't show any cancer cells because it's just a sampling error. So you have CSF that's in your brain and it's traveling all the way down your spine and coming back. So if we take a little bit of that spinal fluid out and look at it underneath the microscope, it may be that we just didn't pull off the right one that showed cancer cells. So typically our thought has been there's more cancer cells in small cell patients in and around their brain than we can see. That may be getting ready to change. We already have talked about the different cognitive effects that whole brain can cause. I would say if anybody has had whole brain radiation, there are a couple trials now that have looked at this medicine called memantine, and it's a medicine that can be used to help preserve and improve neurocognitive function, and it's best if you start it sooner rather than later. So that is a medicine to discuss with your doctor. It's pretty simple to take. I mean, I'm sure when you get it at CVS or whatever, there's a million side effects that it can cause a million things, but most of my patients do really well with it. And especially after PCI, it helps too. It's been shown in a couple trials to help. We're also doing that hippocampus avoidance to hopefully help with those memory issues as well. Part of the reason that I say that this could be changing, because I think there's a huge prejudice in medicine against small cell lung cancer patients. Everyone has basically said, hey, these patients, their cancer comes back so quickly. These cells are so aggressive after chemotherapy and radiation. If we do radiosurgery, if we do gamma knife to these patients, they're not even going to live that long. So let's just do whole brain and be done with it. And I think that's where all of this is changing right now with immunotherapy and with targeted therapy. I think radiation is going to have to change as the systemic therapy gets better. And so that's why I like having young people, because sometimes old doctor brains become very calcified as well and difficult to change. And when you have young people bringing new ideas, they're also growing up with new medical oncologists who are saying, hey, I've got this small cell lung cancer patient who's been around for 10 years. Why are we not thinking about gamma knife? We need to start thinking about gamma knife in these patients instead of just treating them the way we did in 1990. And that is what Chad Rustovan, who I knew in Colorado. Chad Rustovan is the radiation oncologist who's looking at small cell lung cancer. So if you want to talk about different people who are thinking, Chad is leading groups across the world, actually, thought leaders in how to think about brain radiation in small cell lung cancer. So what he did is he asked a bunch of different big centers all across the world to send in their small cell lung cancer patients. And you guys have seen these curves before. What they found is that most small cell lung cancer patients, these were histories, so this was 10 years ago to 5 years ago, most small cell lung cancer patients with cancer that had spread to their brain were only living about 8 months. What they found, however, is that in many patients, so in about 40 to 50% of patients, they never developed cancer in their brain. And so they said, well, that's kind of weird. So why are we giving these patients brain radiation if they're not going to develop? If 40% of them, if we give 100% of people brain radiation, we're over treating 40 out of 100 patients because they're never going to develop brain metastases. And just so you can think about whole brain radiation, this is how I explain it to patients. Whole brain radiation is like painting with a really broad brush. We're just doing brain radiation over the whole brain. Whereas radiosurgery is like we're painting with this fine-tipped paintbrush. We know exactly where radiation is going to go, and we're going to target it right there. And so the difference in that is this study that Chad has done, and he's doing a great job in getting people onto this study. And they're looking at, should we do radiosurgery? And I can tell you that this would have been crazy 5 years ago, but Chad's just a huge proponent of this. Should we do gamma knife or radiosurgery, or for patients whose cancer is spread to their brains, or should we do brain radiation that spares the hippocampus? And this is a study we did in non-small cell lung cancer, 25 years ago. But because patients are having such a great response to the new systemic therapies, we have to think about the fact that we can't just keep painting every small cell lung cancer patient with a broad brush. We've got to start figuring out who doesn't need whole brain radiation and who we can just give gamma knife or radiosurgery instead of whole brain radiation. I think they are trying to get about 150 patients, and they've got probably about 30 patients so far on this trial. So it's open all over the country. And I know that it's open at Wake. Christy Kramer is accruing patients at Wake on this trial. So I think it's going to be great. And I think that probably in a year or two, you're going to see Chad update this at our meeting, which is usually held in September, October. And I think, again, this is, to me, a young radiation oncologist who is looking at this and saying, let's have the answers. Let's not wait. Because as patients, you don't want us to be like, let's wait 5 or 6 years and see how everybody does with this immuno-targeted therapy, and then we'll get the radiation trials going. Like, he's kind of doing this in conjunction with that and saying, as immunotherapy and targeted therapy gets better, let's have the radiation answer ready and waiting when these patients come out. And so I think in both of these, you have the PCI trial that's saying, okay, in patients that don't have cancer in their brain, let's see if we can spare the hippocampus and maybe help with the memory. And then in patients that do have cancer in the brain, maybe we can do a better job of doing a targeted therapy with radiosurgery rather than just painting the brain with a whole big brush. So that's sort of the overview that I wanted to go. And I'm sure that there's a lot of questions on that because I know radiation gets super confusing. But again, I'm very optimistic about brain radiation. And I'm optimistic. To me, when the national group is investing in a trial like this and is approving a trial like this, because this is so much work for everybody to get approved. The fact that they are doing this says that people are optimistic about where we need to be as the oncologists catch up with their systemic and targeted therapies. So I'll go ahead and stop there, and I'm happy to take any questions.
How quickly, once recommendations are changed, do insurance companies cover the new treatments before having to go through older protocols?
Oh man, insurance companies. I will not go into that. So right now, insurance companies would not pay for upfront gamma knife, which is way more expensive than whole brain radiation. They would not pay off trial for gamma knife or radiosurgery for brain mets for small cell. So it's usually, the hard part is usually waiting for the patients to follow up. So once the trial opens, depending on how fast they accrue patients, it could accrue patients, or patients could join the study very quickly, and you could have the answer, within a year or two. But it's usually between 3 and 4 years when they present it at one of our meetings. And then at that point, they start to go to cancer, or they start to go to Medicare. It's basically Medicare that sets a lot of this. So it's usually about 3 to 4 years from when the trial opens, and usually within 6 months to a year after it's first presented.
But they're looking at whatever the standard of care is for that particular disease.
Yeah, and right now, whole brain radiation is still standard of care. I will say again, might be way in the weeds, and I really apologize. Radiation oncology is undergoing a change in how it's reimbursed. So similar, it used to be radiation oncology. For those of you who've gotten billed for radiation oncology, you see all these weird things that you're like, what is that? I've never even heard of that. I don't even know what that is. The billing for radiation oncology, I think within the next 5 years is going to go to a group. So kind of like if any of you have had been pregnant or have had like a knee surgery or whatever, your insurance company just gives the hospital like $20,000 and says, do whatever you want. Here's the money, however you want to treat it. So rather than billing like each individual, like, paperclip or whatever, or however they bill with radiation, and that might change because then it will just be up to the hospital to decide what type of radiation. I'd like to say the doctors, hopefully, but it will be up to that individual provider to figure out how that radiation is going to be distributed based on not payment.
So I have another one. Are there
Sure.
long-term side effects of radiotherapy to the chest for small cell lung cancer? Do I need to worry about lung fibrosis or other effects developing years after treatment?
Yeah. So oh my gosh, I'm going to pull out my soapbox. So just get ready. Depending on who reads your radiology reports, your radiology report will always say like radiation change, radiation fibrosis, radiation pneumonitis. Radiation is, you can't give radiation without, it's like a surgery. You can't have surgery without having a scar. Same with radiation. So there will always be radiation change in the lung. Some of that is due to radiation. Some of that is going to be scar tissue as well. All of that, for the most part, is going to be asymptomatic. In the past, when we did radiation trials, we had a hard time predicting how radiation was interacting in the body. I mean, think about it. I was present when I started my training 20 years ago. We weren't even doing CAT scans to plan radiation. We were just looking at a chest x-ray and like planning how the radiation was going to go on a chest x-ray. Like I remember that. So we just didn't know how radiation, like you didn't know where their heart or the aorta or anything was. So there were a lot of old side effects that came from just not knowing that. Now we have CAT scans, we have PET scans. A lot of you have had scans where you've had to breathe funny. We're just doing a better job of controlling radiation. So the chance of that scar tissue in the middle of your chest or in your lung causing you any symptoms is very low, but you're always going to have that change. Radiation pneumonitis, if you Google it, will freak you out, and you will see that in a radiology report. And I call every single radiologist and tell them to stop writing that in their reports, because obviously you guys are like getting your reports at like midnight on a Friday, freaking out that you're going to like not be breathing and going to die over the weekend. And radiation pneumonitis is very, 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 very rare in 2024. So radiation fibrosis, radiation change, radiologists just love to talk about radiation damage to the lungs, but that actually causing symptoms in you is very rare.
PCI is considered WBR. How often can this be done?
So whole brain radiation and PCI. PCI is whole brain radiation, but whole brain radiation isn't PCI. So whole brain radiation just is treating the whole brain. And PCI is just a form of whole brain radiation that's to a lower dose because there's no evidence of cancer in the brain. So for PCI, you would get about 24 to 25 units of radiation. For whole brain radiation treating cancer that's in the brain, you'd probably get about 30 to 35 units of radiation. So the difference is really in the dose. The target is the same. It's just the dose is different.
I was on, and I hope I'm pronouncing this right, memetamine, whatever the medication you...
Yeah, memantine. Yeah.
I had to write that myself for 6 months. The doctor said that it was all that I could be on it. Is that accurate?
Yep. Yeah. There's no studies on when to stop it. So that's what the study was.
Oh, okay. Okay.
Yeah.
Luckily for some of our clinical trials, there's not a lot of exclusionary criteria, but somebody said they wanted to know, can they be part of the study if they recently had gamma knife to one brain lesion?
So you got gamma knife probably off trial. That's amazing. I mean, your radiation oncologist must not have a kidney anymore because I don't know who they got to pay for that. So that's amazing. Gamma knife for small cell off trial that'd be pretty rare. So no, once you've had that, you could not be on the trial. They should have put you on trial at the beginning. Urgh. I would ask. They may not have even, because that is incredibly rare for insurance to pay for that. So you could ask your doctor when you go in for follow-up. They might not have even put that in as an exclusionary criteria because they didn't think anybody would pay for it. So that's crazy.
All right, another question about lung radiation. It ended up causing her dad's upper and lower lobe tumors to seriously bleed. Is this common with radiation?
Yeah, the radiation doesn't really make them bleed. If anything, radiation stops the bleeding. But what it can do is a lot of times lung tumors, because the lung is where all blood in our body goes through the lung. Sometimes the only thing that's holding blood vessels together is the tumor, just from the tumor growing. So as the radiation kills off the tumor, it exposes those holes in blood vessels, and then they can usually drain. And especially in cancers, I've had 2 patients who have died because their cancer went away, and the only thing that was a wall of their aorta was cancer. And so when the cancer regressed, there was nothing left to hold the blood in the aorta. So sometimes that scar tissue, we actually want scar tissue because that's going to hold those blood vessels together and hold that, be that sort of wall of the blood vessel. But usually that's more of radiation causing tumor response than the radiation actually causing blood bleeding.
I think the next one is more like a comment. Small cell lung cancer patients may have oligometastasis.
Yeah.
So that radiotherapy should be used locally, not chemo and not whole brain radiation. Yeah. I have just one met skin, not brain, from my small cell lung cancer after 2.5 years.
I think we're going to see a lot more again, and this is where old brain, new brain, because I was trained in small cell is very uncommon, hard to cure. Everybody's going to develop metastatic disease. And I think with the change in paradigm of having the immunotherapy and the targeted therapy, your doctors are going to have to switch their brains and think about things like oligometastases, which we've been doing and talking about in non-small cell, in colon, in breast. The radiation is the same, whether it's met from breast or colon or whatever. It's just the thought process of the oncologist that, oh my gosh, this is a small cell with oligometastatic disease. I mean, that's so cool to think about. So that is going to be the thought process is what's going to have to change, and getting the oncologist, the insurance companies, and the radiation oncologist to think about small cell lung cancer as the possibility of having oligometastatic disease is like, yeah, yep, that's cool.
If PCI is given, do they monitor the brain? Oh, sorry, skipped. Do they monitor the brain for metastasis? And if so, how long, how often? And is it just monitored by symptoms or scans?
Yeah, that's the thing. We monitor it the same whether you get PCI or not. So we still recommend every 3-month MRI scans. So that's the other reason that Dr. Rustovan, that Chad and these guys were like, if it's not buying you anything and you still have to go in that loud, crazy MRI machine and spend $5,000 or whatever on an MRI, what are we doing? So yeah, it's the same. It's usually an MRI every 3 months. Some will go to 4 months.
Every time I hear that, I'm like, oh, because I still get them at least once every year.
Yeah.
I'm waiting for somebody to say, no, you don't have to get them anymore. But
I had an MRI maybe like a year ago. And I think it's good for doctors to be patients every once in a while, because people would talk about like how terrible the MRI was. And I was like, oh, come on. It can't be that. It's terrible. It was so claustrophobic.
Yes.
So, it gave me a whole new appreciation. I just sign the order and, give them some Ativan or something. And I have a whole new appreciation of brain MRI when I order it again. I'm like, do you need anything? It's really tough.
Yes, quite interesting. Oh, yeah, but no, bad memory. Look, when considering gamma for the brain at metastasis. Can they do that if the tumors are large or just tiny lesions? And she's speaking about gamma rather than the whole brain radiation.
Yeah. So that is a good question. Yeah, what it looks like is that if a tumor is over 2 centimeters, that again, a lot of this isn't the radiation. It's just that there's not a lot of extra space for swelling. So if you think about the surface area of a grapefruit versus the surface area of a tangerine, if it's a smaller target and it swells a little bit, that's okay. The brain can take some of the swelling, which is sometimes the natural side effect of gamma knife or of radiosurgery. But if it's 2 centimeters and it swells a little bit, that's going to cause a lot more problems, again, because there's just not a lot of real estate in the brain. So usually about 2 centimeters is the cutoff for where they would want to do gamma knife for any brain metastases.
My doctor orders the scans every 4 months. Should this person be asking for them for every 3 months? Is this an insurance issue? I'm not on Medicare.
I would have to look up the NCCN guidelines. I trained at Wake and practiced at Wake, which is a really brain heavy group. So we would continue to do brain imaging, but it may be an insurance issue. That's a very good thought. I'm not sure about that, but I would talk to your doctor about it and just ask them sort of, what do you see and when would you do a scan? And maybe at least every 6 months, I think would be worthy of a discussion.
This might be helpful for some other people. My brain MRI is about once a year. My oncologist asks about symptoms every time she sees them every 3 months.
Yeah, we're in uncharted territory with some of this. There is not evidence. So there's never been a trial looking at when people should have brain MRIs for small cell. So I think people are kind of making it up as they go. And we also know that MRIs are expensive and PCI should be taking care of about 90% of the brain mets. So when to do that at a year, and we don't want to give you more studies. So a lot of it is sort of when data is weak, opinions are strong. So I don't think it's wrong not to do it every 3 months. We just had a tendency, probably because we had an MRI in our department, to probably be over scanners. But I think it's a worthy conversation. But 6 months or yearly, that sounds reasonable.
I haven't had an MRI at all after PCI, and it's been 18 months. No metastasis. Should I push for this?
I don't know that you could push for it, but I think you could come up with a plan for your doctor. What we do know is that gamma knife after PCI, and I say gamma knife because that's what I trained on, but this is, again, radiosurgery or cyber knife. It's all the same thing. It is better if we catch metastases smaller when they don't have symptoms. Mm-hmm. So I understand, and again, this is a mindset change. There wasn't a lot of second line therapy for small cell. So there wasn't a lot of reason to catch cancer early because we didn't have anything to treat it with. So this is a shift, even with doctors that have trained or finished, or even relatively young doctors that have finished their training in the past 5 or 6 years. So I would have a conversation to say, hey, I was at this thing and they were talking about monitoring. What would you think about doing an MRI, every year, every 6 months? Would you be okay with that? Or I just know that there's these trials looking at, radiosurgery, or, I'd rather catch it early. What do you think about being more proactive about that?
Is there a difference between cyber knife and gamma knife, or are they the same thing? And then they had a comment, once I had brain MRI for a year, the radiation oncologist moved to scans every 6 months.
Yeah, radiation oncologists tend to scan more, I think, than medical oncologists. We're just scanners by training. And what was the first part of that?
So is there a difference between cyber knife and gamma knife, or are they the same?
I'm a gamma knife person, so I'll give you my bias. This is like, what's better, a Toyota or a Honda? And I was trained on a gamma knife. So the gamma knife, you actually are bolted in. So you actually have sort of, have you ever seen someone who's had a cervical spinal injury after an automobile accident? You're actually in a metal head frame and you're attached to the radiation treatment machine by a metal head frame. So it can be very claustrophobic. But when you're dealing with something like the brain, you want to be as exact as possible. And a cyber knife, you're not restrained in any way. So your head can be moving, the radiation treatment machine is moving. So the bias that I was brought up with is that Gamma Knife is better than CyberKnife, but and CyberKnives are kind of going out of style. But a lot of people are using linear accelerators, are using the normal treatment machines, and that's totally fine, along with Gamma Knife.
Well, this was very informative. Thank you so much.
I will say, too, for everybody who's thinking about coming at their doctor, this is my little plug, my little survivorship plug. When you're going to, I won't say challenge, but have a conversation with your oncologist, always come with the NCCN guidelines. I think that's a great place to start. And that just puts you on level playing field, and just say, hey, I heard about this and I wanted to talk to you about this, because there are so many other places in medicine to be than oncology. And the vast majority of oncologists, especially people that work with lung cancer patients, are the kindest, most wonderful doctors, and they're the smartest, and they want to help you. But their brains, we are trained to do this one thing, and it is advocacy. And I do feel like, especially in small cell, and especially if you're seeing someone that's even slightly older, to think and to advocate for yourself. And I know it's not fair. You should not have to be a patient and an advocate. I don't know why that is, but that's just what it is. And so to come in and just say, hey, I'd like to have a conversation about this. They might have to go through some cobwebs and some old changing thinking, or, hey, would you mind looking this up for me because I heard about this? You can be like, I heard about this crazy doctor from Atrium. I don't know. I mean, I got broad shoulders. You can just say, I heard Dr. Wentworth talk about it. Do you think it's right or not? There's nothing a doctor likes better than to say that whoever you heard is wrong. So that's totally fine too. So just go in and say, I heard this thing, or heard this doctor talking about it. And that opens up a conversation. And I think that's a really good way for patients and doctors, because doctors are not used to being challenged a lot. And so I think everybody wants the best outcome. And the best way to do that is to come in with, I read this on NCCN guidelines, or I'd like to have a conversation about this. So I think that would be my tip in speaking doctor language.
Just don't say you Googled it.
Correct, Dusty. That's right. I Googled this, or so-and-so's aunt's dog's oncologist told me.
Yeah, thank you. Thank you so much, Dr. Wentworth.
Thank you.
Have a good night, you guys.